Hello everyone, welcome to episode 2 of Rapid 5 series, and today we discuss high yield biochemistry. So vitamin B1, it's thiamine, and it's a cofactor to pyruvate dehydrogenase, alpha ketoglutarate dehydrogenase, branch chain keto acid dehydrogenase, and trans ketolase. And how do you diagnose is by increased levels of RBC trans ketolase. And deficiency usually presents with beriberi. It could be either a wet or a dry beriberi. Wet presents with a high output heart failure, whereas dry presents with the neuro symptoms. Whereas the second, it's gonna be presenting with Wernicke's encephalopathy, which is a triad of global confusion, ataxia, and ophthalmoplegia. And next, it presents with a Korsakoff psychosis, which presents with confabulation. Now B2, which is riboflavin, this is going to be a cofactor to FAD FMN, and these carrying enzymes like succinate dehydrogenase and even L-amino acid oxidase, etc. And then coming to this diagnosis, it is by RBC glutathione reductase. And you can see here at the corner of mouth, this is your cheilitis. This is one manifestation. Other is a magenta tongue, and also it presents with corneal neovascularization. And then coming to B3, which is your niacin, this is going to be cofactor to NAD, NADP plus, and this is required by dehydrogenases as well as the reductases. This deficiency leads to pellagra, which consists of 4 Ds, which is dementia, dermatitis, diarrhea, as well as, if not treated, death. And you should know that 1 mg of niacin is made from 60 mg of tryptophan in the presence of B2 or B6. And there is something called Casal's necklace, which is around the neck. And then coming to B5, which is pantothenic acid, and this is going to be for coenzyme A and as well as fatty acid synthase. And the deficiency is known to cause the burning feet syndrome, which may also present with paresthesias. And B6 is known as pyridoxine. This is a cofactor for transamination as well as decarboxylation reactions. And diagnosis is usually by RBC transaminase levels. And deficiency is known to cause refractory seizures and also sideroblastic anemia. Then coming to B7, which is known as biotin. This is for carboxylation reactions like pyruvate carboxylase as well as acetyl CoA carboxylase. And the deficiency is known to cause alopecia and even dermatitis, and contains a substance called evidin, which is present in the raw egg that inhibits the biotin absorption. And then coming to B9, which is also known as folate, this is a cofactor for methylation reactions which are required for the synthesis of DNA. And the diagnosis is usually by homocysteine as well as methylmalonic acid levels. So increase in a homocysteine level as well as a normal methylmalonic acid levels is known to be for folate deficiency. It leads to macrocytic megaloblastic anemia. And then coming to B12, which is also known as cobalamin. This is for methionine synthase as well as for methylmalonyl CoA mutase. And here it is going to be increasing both homocysteine as well as increasing methylmalonyl acid levels too. And deficiency obviously causes megaloblastic anemia as well as paresthesias and also skid along with peripheral neuropathy. Then coming to apolipoproteins and their function. B48, this is for the chylomicrons. Then B100, this is for LDL, A1 is for HDL, C2 for triglycerides, E is for all except for LDL. And then the most important and recently asked questions from familial dyslipidemias. Type 1 is hyperchylomicronemia. This shows autosomal recessive pattern. The defect or deficiency is from ApoC2 or lipoprotein lipase. And clinically you can see eruptive or pruritic xanthomas, and also you can see pancreatitis presentation. Type 2, this is hypercholesterolemia, which is showing you autosomal dominant pattern, and defect is either ApoB100 or LDL receptor. It shows you Achilles tendon xanthomas, and also it is known to cause corneal arcus. And type 3, which is dis beta lipoproteinemia, the inheritance pattern is autosomal recessive, and defect or deficiency is of ApoE, and clinically it shows Palmer as well as tuboeruptive xanthomas. And next is also known to cause premature atherosclerosis. And then coming to type 4, which is hypertriglyceridemia, which is autosomal dominant variant, which is hepatic overproduction of this VLDL, and this is known to cause insulin resistance, and it ultimately leads to acute pancreatitis. And then the most important of all exams, the lysosomal storage disorder, Fabry's disease. First, it's deficiency of alpha galactosidase A. The accumulated substance is a ceramide trihexoside, and there is no hepatosplenomegaly or cherry red formation, and clinically it shows neuropathies and hydrosis, etc., and even renal failure ultimately. Specific features, if you see, it's going to cause this Maltese cross crystals in urine. Then Krebs disease, which is going to be a beta galactosidase, and here the accumulated substance is a galactocerebrosidase. And then you can see no HSM or cherry red, and you can see optic nerve enlargement as well as globoid bodies can be noted. And then coming to Tay Sachs disease, this is a deficiency of hexosaminidase A, and here the substance accumulated is GM2 ganglioside, and there is going to be no HSM but cherry red presentation is noted, and it presents with macrocephaly and hyperacusis along with onion skin appearance because of neurodegeneration. And then coming to Niemann-Pick disease, this is a deficiency of sphingomyelinase, and accumulated substance is a sphingomyelin. And here you can see that hepatosplenomegaly is present as well as cherry. It shows this zebra bodies as well as foamy macrophages, and clinically it shows neurodegeneration at later stages. And then coming to Gaucher's disease, this is a glucocerebrosidase deficiency, and it is also known as beta glucosidase, and here the accumulated substance is a glucocerebroside, and you can see there is hepatosplenomegaly but no cherry red spot, and it presents with pancytopenia and osteopenia. And here you can see crumpled tissue paper appearance on microscope. And then coming to other, that is metachromatic leukodystrophy. This is a deficiency of phenyl sulfatase A, and this accumulated substance is cerebroside sulfate, and here the HSM as well as red both are absent, but clinically it shows demyelination, ataxia, as well as it's gonna show you this dementia. And because of demyelination there is going to be a tigroid appearance on MRI. And then coming to DNA replication function as well as enzyme, it's one of the important. So unwinding the DNA template at replication fork is helicase. Preventing the reannealing or degradation by nucleases is with single stranded binding proteins, and unwinding of DNA helix is by topoisomerases. Then making the RNA primer to initiate replication is primase. Elongation of leading strand is usually by DNA polymerase 3, and then which is joining the Okazaki fragments is your DNA ligase. Next our topic is your enzyme inhibition types. You have competitive, we have non-competitive, and we have uncompetitive. Competitive shows cross, so here the Km is going to increase and Vm remains unchanged. Non-competitive is going to be V shape, this is going to be Km is going to unchanged, whereas Vm is going to decrease. Then coming to uncompetitive, it's a parallel line, you can see Km is decreased whereas Vm is also decreased. Please do like, share and subscribe for